Well, welcome everyone. Welcome to the second in the series of distinguished health leadership speakers that is sponsored by the Center for Health Leadership at the School of Public Health. We are very honored to have the speaker with us today, Dr. Paul Farmer. And I am charged with introducing, quite appropriately, Melissa Price, one of our terrific students in the school who serves on the Student Leadership Board of the Center for Health Leadership. And it was really the Student Leadership Board that organized this event, recruited Dr. Farmer as our speaker, and so I would like Melissa Price to come forward and introduce Dr. Farmer. Thank you very much.
Hi. I'm going to keep this really short and sweet because I know why we're all here. We're here to hear Paul Farmer speak, not Melissa Price. Medical anthropologist and physician Paul Farmer is the Maude and Lillian Presley Professor in the Department of Global Health and Social Medicine at Harvard Medical School and founding director of Partners in Health, an international nonprofit organization that provides direct healthcare services and undertakes research and advocacy activities on behalf of those who are sick and living in poverty. Dr. Farmer is an attending physician in infectious disease and associate chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston, and has served for 10 years as the medical director of a charity hospital in rural Haiti. Please join me in welcoming Dr. Paul Farmer.
Thank you. Thank you very much. Thank you. Thank you. Wow, this is a nice warm welcome back to Berkeley. I have friends in the faculty who are here. And as I used to say, I was in 1990, I finished my MD and my PhD at Harvard. And one of my professors, my advisor, some of you know Arthur Kleinman, he connected me to the University of California Press. That was right after I'd finished, and I met an editor who I don't know if he's here today, although Naomi Schneider is here and her boss is here. And I wrote, very proudly, this was the day, none of you students are going to remember this, but this was in the day when there was something called a Rolodex. Quite literally, you'd write down, so I wrote Stan Holwitz and his number, 310, whatever it was, he was in LA then. And then a little while later, Jim Kim, I recognized writing right underneath, my editor, with quotation marks. So I see friends from the faculty, students, my editors, and it's really nice to be back here and to have such a warm welcome. I just got to meet with some of the students and met Melissa already, and as usual, I'm always pleased to talk to students. There's probably strict rules against that at Berkeley. To talk to students, and I'm going to try and shuttle today between some specifics, mostly things that I haven't spoken about since the last time I was here 4 years ago, and focusing a little bit on Africa, and some of the work Partners in Health has done, but also shuttling back and forth to some very broad questions, including the difficult ones. What is it really that a university ought to do as it increasingly spans, as research universities like UCB increasingly span borders of all sorts, whether they be county, state, or national borders. How do we comport ourselves in the world? And so I'm going to try to, as I said, go between the specific and the general. I would add also that when talking about human rights, as I was this morning in San Francisco with a group of concerned citizens, it's always a good idea to try and link these large-scale questions to pragmatic considerations. And I don't want to embarrass Nancy Shepherd-Hughes, but I just want to say thank you to Nancy Shepherd-Hughes, with whom I've been conversing about all these issues for now a quarter of a century. Am I allowed to say? 30 years, actually. So I think this is to be a little bit prescriptive with those of your students, I think this is an exercise that's very, very helpful to me. Now, I really am not focusing on specifics. I have left the reference in here, but I really want to focus on the general question, because public health, and I'm here as a guest again at the School of Public Health, Public health is really, our religion now is cost effectiveness in public health. And I was speaking with students an hour ago talking about what did public health look like in the 19th century and how has that changed now. Obviously, a lot of the changes have been for the better in terms of knowledge acquired, the knowledge base that has been acquired in public health, as in medicine and science in general, and the social sciences relevant to public health. But in some ways, there's been a cost as well of always funneling down away from social reality. Now, I hope that I'm not saying this because I'm also an anthropologist, but desocialization of what are fundamentally social epidemics is a huge problem in medicine and public health. Now, you wouldn't want to hear this from your surgeon as you were heading into the OR. You know, the surgeon's leaning over and she says, by the way, I'm going to assure that I'm going to do a fully re-socialized surgical procedure on you. You don't want everybody, those who have talents to be in the lab, for example, to be thinking about this all the time. But I do believe that it's a generally significant problem. And some of us in the question and answer session will talk about national health insurance programs and problems that are facing this country. Desocialization has been, in my experience, central to a lot of these analytic errors that I'll be describing here today. Now, I just want to take most of you read, I'm just worried, question, how many of you are public health students or medical students? So maybe a quarter of you. This is a little bit focused on your interests. But The Lancet, since this is a more general audience than I had understood, The Lancet is a medical journal, and as I've said before, I just love the names of medical journals. The Lancet. I mean, that is a truly downwardly mobile name. Leslie, been looking for you. So The Lancet's a medical journal, very influential, especially in global health. It's a journal from the UK. Speaking of downwardly mobile names, the name of the main gastroenterology association journal is Gut. So anyway, it's important what gets written in these journals, and this appeared in 2002, and the reason I put the date there is because it was published in time for a major biannual conference on AIDS. And I had sworn them off. I went to Durban, and in 2000, the first time one of these conferences has been held on the continent, the most afflicted conference. These are conferences about AIDS. And it was a very strange thing for me to go from Haiti to Durban. Now, a lot of the strangers had to do with the fact that I went via Siberia. I went via South America for that one. And so I went from Haiti to Miami to Peru to Santiago to somewhere in Brazil to some islands like the Canary Islands to Joburg to Durban. So needless to say, I was a little bit stunned when I got there. And it was a very strange, it looked like Fort Lauderdale. Those of you who've been to Durban know what I'm talking about. And here you have a country where there are so many poor people who don't have access to basic medical care, and these towering hotels and seaside resorts. It's a very unusual place. And it's beautiful, don't get me wrong, but it was very strange to go into this huge conference with 15,000 people and to spend a lot of time arguing that maybe, just maybe, the confident claims that we could not treat AIDS in Africa were not a good idea. That did not strike me as a very pleasing use of my time as either physician or anthropologist, and so I left the meeting a little day early, I remember, and said, I'm never going to another one of these meetings again. And then in 2002, I was invited to give the plenary address, and I said, sure, I'll be right there. So that time it was from Haiti to Barcelona via Siberia. No direct flights. And I decided I would write out every word of my talk, and so I was reading in Haiti, where we had put in high-speed internet, I was reading these papers, and I couldn't see the references in the format that I had available to me. And so I asked my research assistant, who's now in a doctoral program, can you find these references for me? What are they about? And she said, well, one is about a mathematical modeling exercise. Because you notice there's a curious specificity here, 28 times. It's 28 more times to prevent than to treat, is what this basically says. And now, I had a lot of problems with this whole idea of pitting prevention against treatment, as is done all the time in public health. I always thought that was kind of a goofy thing to do, analytically. That's how we say it in scholarly circles, goofy. But I wanted to know what data was informing this, and there were two data points. One was a mathematical modeling exercise, and the other was from a program that hadn't yet been even initiated. It was like a NGO costing exercise, which really struck me as troublesome. Again, now, some of you in this room are mathematical modelers or play them on TV. And I'm not trying to offend you, but I would say that for those of us interested in scholarship, there tends to be a very large margin of error in mathematical modeling. You don't have to watch television shows like 24, when they say, we're going to be nuked, and either 4 people may die or 4 million. That's the kind of margin of error you get in mathematics. So I didn't think that was really the best way to drive forward a serious policy decision. And I asked my coworkers at Partners in Health, the director of procurement. Actually, at the time, she was the only member of the procurement team, but it sounds better to say director of procurement. So I wrote to Catherine and said, how much are we spending on these drugs? Because, to make a confident claim about cost effectiveness, you have to understand cost and effectiveness. Now, forget about social costing, which many of us in anthropology are interested to do, and others working in social science. I wanted the data. And this is what she sent me. She made me this slide for the Barcelona meetings about which I was so nervous, because I was going to speak in front of 15,000 people. By the way, IDA means International Dispensary Association, the world's largest nonprofit procurer of drugs, and it's in the Netherlands. And a friend of mine from IDA, who is, as many people in the Netherlands are, Dutch, was there with me in Barcelona as I was nervously preparing to speak in front of 15,000 people. And he said to me, Paul, you've really made it. Queen performed here. And I said, you trying to make me nervous? Anyway, back to the data. So the average wholesale, it doesn't matter, you don't have to be an infectious disease doctor, but the average wholesale price for 2 regimens are up here. And then they're about $10,000 per patient per person. Now, in public health, and this is kind of a warning to the students, don't let drug costs be the end of a conversation about something for which we have a therapy, like diabetes. Don't let that be the end. That's got to be the beginning of a discussion. Well, why do drugs cost so much? How is pricing done? Does it have polonium-210 in it or diamonds, in the medicines? How is scarcity created? And so the $10,000 per patient per year issue is another thing that we ought to talk about, because that's still the problem. But then PIH that year, 2002, was already paying $700 per patient per year for these regimens, with a mix of generic and conditionally priced drugs. And then finally, the IDA in the Netherlands had already renegotiated some of these prices with generic manufacturers down to less than $1 a day, which some people would say is not an unreasonable price. And now, after the Clinton Foundation got involved and Doctors Without Borders and other NGOs stopped saying, gee, we can't treat AIDS in Africa, now the price is about $90 per patient per year. And it's still $10,000 per patient per year, mind you. But I'm saying this needs to be the beginning of a discussion, not about AIDS treatment, because now we're well into that discussion, but about basic good things for poor people who are facing illness. Think about major mental illness, think about coronary artery disease, think about on and on the list goes. Chronic disease is a serious problem that poor people in the world in general are facing here and elsewhere. So that was on the cost part, and we're going to talk about effectiveness in a little bit. Now, I had a good fortune of meeting a lot of these people who were dying of AIDS, and I said to them, all right, already, stop dying, won't you? And when I was last here, I showed this picture at Berkeley up in the corner of a young man. I told you his story. I'm sure you all were there and hung on every word. But you'll notice that when people are dying of a wasting disease, they kind of look alike. Into the end, we all look just alike. But this is another guy who, and I meet patients like this all the time. I chose these two, and this is a young woman who works with us who's dying 10 years ago in her home. And I didn't tell this story before, but it sounds like all the others. And many of you who have done work like this know the story. So we go, it's a home visit. It's a long way, actually, to this woman's house. And her father says to me, I'm wondering if you, or PIH, whatever, could lend me some money to buy her coffin. And so, we said, well, let's not buy a coffin. Let's get antiretrovirals, which are the only treatment that we have still to this day for AIDS. And then there's a year later, and then with her coming out to her. Now, this is a very, very complex health model. I don't think I'll be able to describe it to you in under an hour It's a community health worker and a patient. As our former president would say, it's not nuclear science. Actually, there's a University of California Press book, which I saw, the catalog. It's a study of George Bush's speech patterns. It's called Going Nuclear. Is that not true? It's on your catalog. Lynn, where are you? Anyway, so it's not a complex, it's a good model, and we'll be talking, some of the people I talked with today, talking about, can't we use stimulus package money to have community health workers in the United States? Let's return to that in a minute. The reason I chose these two pictures because, and here I was stretched. Some of you, actually some of the face aids kids were there. Kids is, by the way, the local indigenous term for anyone under 24, kids. I mean, it means also small goat, or to me, it meant small children, but now 22-year-olds call themselves kids. So some of the kids, anybody here from Face AIDS go to this conference? Did you go to the conference? Do you remember these two people? So they had never left their country before, and we said, well, they've been on ARVs for 10 years. Let's invite them to our annual PIH symposium. And so there they are, Adeline and Saint-Cœur, which of course means what? Holy Heart. It doesn't get better than Haiti. So they fly up there, and the director of Partners in Health, Ophelia Dahl, said, Paul, and no offense to those of you who are Haitian, you'll know what I'm saying is true. Haitians tend to be chatty people. They have 5 minutes each. Go brief them. That's how I get my orders. So I go and sit with them, and I said, what are you going to say tomorrow in front of 1,000 people? And they said, oh, we're not worried about it. We do public speaking all the time. So let's talk about, how about Obama? So they didn't want to talk about their talks, and I couldn't force them to. So the next day, it's 1,000 people or more, the two of them on the stage, and me, their translator. And I was way more nervous than they were. Not as nervous as in front of the place where Queen sang, mind you. But so the opening gambit, you can look at this. I pulled this off the web. This is all podcast or webcast or whatever the jargon is. Ask someone under 40. Anyway, so this guy starts speaking. He said, first of all, and he's speaking in Haitian Creole, of course, and I'm translating. I'm looking at him, 1,000 people. First of all, I'd like to thank all you bourgeois people for your help. So the Haitians in the crowd and some of the doctors who worked at Haiti, they just cracked up thinking, how is Paul going to translate this? Now, why did I put first line up here? 10 points to Gryffindor, if anybody can tell me. So the public health people here who focus on infectious disease know that there's something that happens with all infections, parasitic, viral, and bacterial, drug resistance, right? So one of the scariest things I saw in public health in the last 10 years, I'm not sure that I deserve to be a public health hero, was the arguments that we shouldn't use antibiotics for poor people because we need to save them. Save them for whom? And, the arguments about drug resistance, it's pretty scary, the language in which it was termed, that we don't have the infrastructure, that we don't have to do this in so-called resource poor settings. Here, I showed you the infrastructure right there. And people say, well, you don't have the lab infrastructure. What lab infrastructure do you need to treat AIDS? Almost none. It'd be nice to have some, but trust me, it's not nuclear science. So you don't have the infrastructure. Then people actually said, who didn't know what they were talking about, well, you have to be able to refrigerate the medications. It's just not true. So there are all these, and I've cataloged in one of my effervescent books for you, Naomi, the ever-jolly infections and inequalities. I was at the University of Texas just a few months ago, and this kid comes up to me and says, oh, Paul Farmer, I thought you'd be a grumpy old man. And I said, well, why? And he said, because I've read your books. Anyway, so I made the whole laundry list of all the reasons that were given not to offer poor people standard of care. And it's a long list. And some of you, especially maybe some of you who are doing medical anthropology or medical sociology, will have found lots more than I did in my reading. And I got tired of the topic. It was just such a long list. But the argument against using this, that it will stall the development of resistance, is just not true. Anybody who's worked around poor people who are also sick know that their families are always going to do what families do. They're going to chip in. Drug-resistant TB in Peru, when someone says it's not cost-effective to treat it, don't. That's not going to fly with family members, loved ones. So rest assured that either we take public health control over these interventions or we leave them to be 1,000 points of light. And trust me, that's a better way to create drug resistance than this model, which actually Here you got people 10 years out still on their first-line regimens. And I wish they'd do this more in South Africa and Brazil, for example. Probably in Brazil and Argentina, 75% of public expenditures that are being used on AIDS drugs are all for the second and third line drugs, because they don't have community-based care with accompaniment. That's what we call it. Community health workers actually making sure that the patients are able to adhere to these regimens. Now, I told you I was going to talk about health and human rights. How am I going to segue into the human rights question? Obviously, it's perfectly legitimate for a doctor or an anthropologist or a human rights specialist, whatever that may be, to say, well, it's important to respect individual rights, like those two patients, Sankar and Adeline, or the thousands of others. But we're also interested in population-based rights. Nancy has written about this. How can we scale up, and what is this in question? It's not just AIDS treatment, it's basic primary health care. So some of you maybe are going to ask about, well, do you really want to have vertical interventions like this? The answer is no. You want to build systems that can respond to needs, whatever they may be. I mentioned already other chronic diseases, but what about obstructed labor? I was really shocked this morning. I was on Michael Krasny's show again, and he started quoting, believe it or not, from the World Journal of Surgery, an article that I'd written. So if you have very thorough radio journalists out here, because most of them do not read the World Journal of Surgery. My mother reads it when I publish it. Anyway, so every one of these red dots is one of the places where Partners in Health has gone into the public sector and tried to rebuild these dilapidated public sector hospitals and clinics. Now, why public sector? Some of you already know. It's obvious to some people. It wasn't obvious to me 25 years ago. Public sector because only the public sector confers rights, not NGOs, not universities. Even UCB, as I read in the paper this morning, you don't have a right to go to the University of California, Berkeley. But you do have a right to go to high school and primary school. And those rights are conferred by the public sector. Clean water rights, education rights, health rights. So we, like most NGOs, took us forever to figure this out, which is too bad. And that's why I'm sharing it with you. Don't do that. Don't do what we did and bumble around by yourself. Work in the public sector if you can. Now, in some of the places I've worked in Latin America, I've been told by my interlocutors, don't work with the government. They killed our families, and they did. So it's not always possible, but it's mostly possible to try. There are extreme situations where you're not going to do it, but that's why. Scale and rights. And I tell you, my undergraduate class, or the undergraduate class that I teach, my little undergraduates, that's what they say in medicine, my intern, my resident, my fellow. Anyway, this undergraduate class that I taught, full of young people called undergraduates, if you went in a room like this and said, what are the two reasons to work in the public sector? They'd say, scale and rights, and roll their eyes as if, because it's an important part of the recipe for NGOs. Now, when we, by the way, I have to admit I was very personally disappointed because a friend of mine who's a real expert in quality improvements and scale up, and I showed him this map, and he said, Paul, that's not scale up. I said, it isn't? It felt like it. It was hard. And he said, oh no, that's contiguous spread. So whether you call it scale up or contiguous spread, and I don't care, you can take this model of comprehensive care. That's like Berkeley in the 60s. Comprehensive care and use AIDS and other very vertical programs to drive that forward. I didn't show really what that looks like on the clinic level, but I would be glad to talk about it in Q&A. But what about Africa? Now, this is in western Kenya, in Luoland, actually, recently prominent. There was a great joke going around in Kenya that the United States was more likely to elect a Luo president than Kenya was, which proved to be true. I'm actually in the back, in the middle. I don't know if you see me. Now, that's really not a funny joke because, what's missing from this picture is adults. Now, grant you, this is a school. And it's a primary school, so it's kind of a setup for the photograph. But I went to this part of Africa, and there's lots of old people and lots of kids, but there's a missing generation. So if you want to do social costing, right, and I talked about social costing, and some people here will, I hope, pursue that topic as, say, an anthropologist or whatever field, think about that. Think about how would you begin to cost that? How much does it cost to have a missing generation? especially if they're the young adults who were doing the farming. And you know, I thought about this. I thought about this as I watched a fairly elderly woman hoisting up these two kids, her grandchildren. And it's not easy to pick up little kids, you know, when you're getting old. So who's costing that? You know, the wear and tear on the fabric of society, on the economy, the culture, even the kinship network. And I think it's an important activity. We wanted to go to Africa for this reason. We thought we, Partners in Health, had some expertise working in the public sector, working in post-conflict settings, kind of a goofy term, but we knew what it meant, and working to use AIDS money to strengthen primary health care in general. And so at the same time that the Rwandan Ministry of Health came to us, President Clinton and the Clinton Foundation said, we want you to work with us in Rwanda. And actually, I went to this place in Western Kenya on another mission of mercy, I hope, to look at improving AIDS care there. Because, and here, I'm just going to say this in a very diplomatic way. This was only a few years ago, and the logic of cost effectiveness had been applied with grim rigor to these projects in Kenya that we were evaluating. And the idea was, it's not cost effective to treat AIDS, therefore we're going to do home-based and palliative care. Now, I went on home visits to these home-based palliative care programs, and let me tell you, there's no way around it. If you're dying of AIDS, there's only one way to stop dying of AIDS, and it's not palliative care. It's not antifungals, it's not morphine, it's not IV fluids, it's antiretrovirals. And so finding a diplomatic way to say what I was thinking, which is this is community-based no care. It's community-based, but it's not no care involved, so it's something other than community-based care. Community-based absence of care. Scary stuff to find a diplomatic language for that, which I did, I hope. Because a year later, I went back, and these series of programs, which are funded by a large organization, which I won't mention by name, but which is Catholic and gives relief services, they were doing the right thing the next year. And of course, all these people who had been, as they say in Kenya, down, were now up. They were back in their gardens and taking care of their kids, because this is decent treatment. It is not curative, but it's like with diabetes treatment when you use insulin. It works. Anyway, so we were on our way to Rwanda, and the first place we went was in northern Rwanda. So how many people have been to Rwanda? Pretty remarkable place, I got to say. Not too many of you. And we went to northern Rwanda to a place called Ruhengeri where the gorillas are. I actually was wearing this suit and showed up, and it said on my schedule, gorilla visit. And I said, really, like in the mountains? And so I went up there, all these groovy European eco-tourists with weird hats and things, looking at me, and the gorillas were looking at me. Who is this guy in the black suit? Anyway, but then I went to the hospital nearby, the public hospital. It had electricity, 3 doctors, x-ray machine. So I'm back to the city, talked to the minister in the this cabinet level position, and said, you can send us somewhere more difficult. Now, I've later re-diagnosed this as a case of public health machismo, which I think I should have done, to have a little bit of self-reflection. I said, you can send us somewhere more difficult. We're partners in health. We're tough. And they said, okay. And they did. So that's how we ended up, and we later moved here. This is Ringwavu, which sounds great, but it really just means land of the rabbits. And we were sent to an abandoned hospital, but we had a lot going for us then. This is a public sector facility. Has anybody been to visit this place? You know what's coming. So we went there, and we had some secret weapons that we didn't have 20 years ago. We had the Haitians. So we went with the Haitians, our colleagues, said, come to Africa, come to Rwanda and Malawi and Lesotho, help us implement the things that you know how to do, which involve rebuilding public infrastructure, training, research. We knew what we didn't have the magic recipe, but at least those things were the 3 primary activities. And we also said things like, when you're doing infrastructure rebuilding, it's not a good idea to say, gee, we're closed for restructuring. They've been closed for restructuring. That's what that looks like. So we said, we've got to provide services, and we actually had to go out to the marketplace and buy sheets, And the nurses, we were the doctors at that point, the Haitians and the Americans. We said, well, we'll be the doctors, but and they said, we don't want to, where are we going to sleep? I said, well, we might have to sleep on the floor for a while, and then we'll build a dorm, chill out. And when I said that, it didn't go down very well, but when the Haitians said it, it was much more compelling. They said, come on, buck up. We went through this already. It'll be fine. And they also said, and you'll see people like Joseph, the first guy I showed 4 years ago, come back from the dead. And of course they did. But it's not nuclear science, and so we went into the wards, which were abandoned. Who would go in there, by the way? What Rwandan mother is going to want to take her children or a child, sick child, or anybody to a place where there's no doctor, there's no nurse, there's no medicines. No one's going to go to these. They're empty. Plus, they have user fees often. They're bad and costly. So, of course, people are not stupid. They don't go. But it fills up immediately. Inshuti mu buzima, as you all know, means partners in health in Kinyarwanda. I thought I was talented with languages, but I have to confess to my anthropological colleagues, I was mistaken. Romance language is easy. Kinyarwanda, not easy. Anyway, I'm working on it. And we went into the operating room and, redid the operating room, not nuclear science. Pharmacy. And I mentioned already my Haitian colleagues like to brag a little bit about them. This is a Haitian doctor, but he's not in Haiti. He's in this picture in Lesotho. And this is a Haitian nurse, but she's in Rwanda. And, that was a very critical, I see so much money wasted on consultants. It's just a really troubling part of this work. Some of the public health students ask me, what would you do to restructure foreign aid? I get rid of at least half the consulting fees. No offense to McKinsey, if you're here. I'd like to meet McKinsey, whoever she is. Some little public school laughter, nervous there. Anyway, I'd cut out half the consulting fees and get people like the Haitians to go help. They already work with us. They just showed up and started working. And if we could get USAID to change a little bit along these direct lines, it'd be good. But it works, and the same sorts of things that we saw in Haiti and Peru and elsewhere happen in Rwanda. We saw people come back from the dead. And again, talking about social contact, of course, all of these people have asked that I use their images, in case you're wondering. There's a woman named Solange. They say, use our names too. And she's dying. She's dying in this picture, as you can see. But imagine the impact also, thinking about social costing. First of all, of having young people die bad, with families, but also of the impact on public health and the local community investment on public health when you've gone from an ugly or abandoned hospital to a place where instead of giving death or being associated with death, you're actually associated with restoring life. And again, I should have more pictures in here of the community health workers, the lay people who actually are trained to assure that this works effectively. They all it's part of the model. But I think, one day, I'm not a student of this, or don't study this, but one day we'll get someone to give us a good assessment of how important it is to rebuild people's faith in public health. Now, what about outcomes? So this is the first 200, we have thousands of people on therapy now, but the first 223 people on therapy with a community health worker for 2 years, 98% suppression. Now, you don't have to be a doctor. I'll just go through this. That means that this is very effective, that they don't have any trace of virus in their blood at all. It's pretty, and I'll compare with U.S. results in a minute, with U.S. inner-city results. At least I hope I didn't take them out. And how much does it cost? Well, the community health workers cost less than 5% of the overall cost. So the argument, by the way, guess which argument is made against paying community health workers? I'm sure it's going to stun you. Not sustainable, not cost-effective. The same bludgeon, that is a noun also, right, that has been used to trash all of these investments in public health. The same thing. And this is, by the way, what we're struggling against now, today. After all these years of doing it, it's still saying, no, it is cost-effective. No, it is sustainable. It's the dominant religion in public health, and it's particularly perniciously applied in poor countries by international agencies. Now, what about the United States? Someone was asking me earlier in our session over at the School of Public Health, and I said, well, what we're trying to do is to show how important it would be to have good community-based care in this country. And I could give a lot of reasons, but the main one is this. This is just with AIDS. I mean, we could do the same exercise with diabetes and hemoglobin A1C, or whatever you were looking at. But this is from Emory, from Atlanta, actually, and a friend of mine, Carlos Del Rio, showed me these data. He presented them at a meeting in 2001. I said, you really ought to publish this. And he said, well, it's kind of embarrassing, isn't it? I said, no, it's kind of reflective of what there is in our country for poor people. It's very expensive to give bad medical care to poor people in a rich country. And since the dominant religion is economics, show how much it costs. Because if people don't care what it costs in lives, they may care what it costs in emergency room visits or whatever, and I'll return to emergency room visits in a second. But basically, this is the exact opposite of what we saw in Haiti and Rwanda. Most people do not have suppressed viral loads. Most people are not responding to therapy. Why? Because the drugs aren't getting in their bodies. And you could say, well, they're addicted, they're addicts. That's, on that list that I mentioned in the Ever Cheerful books I write for Naomi. But yeah, so they are in Boston too. And we use community health workers with our patients who are addicts, and they do fine. And I said, I get into trouble sometimes because I can be smart alecky. I said, well, if it's one thing people who are addicts know how to do, it's take drugs. That didn't work, so. But anyway, we basically this intervention is critical for the future of medicine in the United States around chronic disease, community-based care. And that doesn't mean community health centers, it means community health workers, not home health aides who are working in one place as fee-for-service commodity kind of stuff. Community health workers are promoting not just care, but prevention. That's what we do in Boston. I got in a little trouble and I said, look, all we're trying to do, this is for a picture from Boston, same thing. Community health worker goes, and actually one of my co-workers is here today who worked on this. The community health worker goes into the home, and it's the same model. I got in a little trouble, as my coworker here knows, when I said, look, all we're trying to do is raise Harvard levels of care up to Haiti levels. I know, that was probably not wise. Here's an example from one of the patients. I probably didn't need to do this because it's more for the medical and public health people, nursing, etc. But basically, the red marks, the hash marks at the top, are emergency room visits at a very large Harvard teaching hospital I won't mention by name, but I worked there. And if you're an economist, a health economist, imagine what that might cost in terms of unpaid billing, because this is not going to be recovered from the patient. And they have a very low CD4 count, which means the immune system's destroyed, and a very high viral load, lots of virus. And the viral load doesn't drop until they start getting the ministrations from us at the green line. But the only way to get viral load to nothing and CD4 count up and stop the emergency room visits, which is something you'd be interested in if you were only interested in the health economics of this, was the same type of Haiti-style intervention. That's what we call accompaniment. You're accompanying the patient. Now I want to close by going back to this large-scale kind of way of seeing things and open this up for discussion. And I like going back to this quote. I go to it again and again. And I'm not sure, maybe someone in this room will remember when he said this or where. I think maybe in the letter from Birmingham jail. I don't know. Somebody here will know. But he was really, Martin Luther King was really on to something. That it may be, you hear things about American culture not being focused on equity, and and there are studies by sociologists of this country. I grew up in it, but as they used to say a long time ago, I'm soaking in it. I don't study it very much, but that there's this American ideal that we should not focus on inequality, we should focus on individual opportunity. Again, some people in this room have written about this. And that may be true, and I suspect that it is if that's what they're writing based on empiric research. But it is not true that people are not interested in equity around healthcare. And some may observe that maybe it's because anyone could imagine what it might be like to be poor and sick and alone, or at least sick and alone and unattended to. And that's maybe what Martin Luther King was getting at. I guess my point is, for those of you involved in public health, and I thought that would be the most of the audience, is we should use this as a wedge issue. Equity of access to care, I'm sure we're going to talk in discussion about universal access to care and medical care in this country. We should use this as a wedge issue to push forward a broader social justice agenda. I think there's a lot we can do. Now, what role for a university? This is my closing salvo. See, now you're laughing. Had to study the slide. And there was an article in the paper about this after I made this slide. I think it was this morning. Was there an article about public universities in turmoil and trouble? I was kind of thought about pulling the slide because, I figured you guys are having some problems here, I've heard. But forget about the budget for a second and think about the model, right? What is the model of a place like Berkeley? It's to do training and research. That's the mission statement. But without the service component, it's very hard for universities to be involved in global health equity, whether that be in Oakland or in rural Rwanda. And training ourselves as a university community to make the slice of that pie around service a little bit bigger, I think is one of the things that we can do in order to avoid having all discussions of rights be abstract, seminar room feuds. And these are real issues for anybody who's part of a university. So I want to close with that provocative statement with a thanks to a couple of groups that I know work here. Some of them are here, Face AIDS, which is a movement that started at Stanford but spread across a lot of campuses, I think probably 140. And what they did was ask that question, how can we, as students, contribute to addressing these disparities of access to care? They were focusing on one illness, but I think that kind of pragmatism can be coupled to vision. Another is Universities Allied for Essential Medicine. There's a strong chapter here at Berkeley trying to ask, again, this basic question: what does a university owe to the rest of the world, and specifically to people who are living in poverty? So thank you very much, and I look forward to discussion. Thank you. Thank you. What's the mic situation? All right, we have a mic. Oh, I can repeat it if you're, cloistered in the middle of some. Of course, it would be bad if there were no questions.
Oh, well, if anybody in the audience has questions, we're the mic runners. So.
Hello. In the countries where it seems that the adults are either absent for whatever reason, high HIV rates or whatever, or there's youth are not getting proper education, like in Haiti, no more than half of them go past the 5th grade. Is anything done to kind of help them build their skills as well as building infrastructure and even public health infrastructure?
Yeah.
Like training them to create public health infrastructure, being accompagnators for other youth peers, or even in service.
Yeah. Well, thank you very much, and the answer is yes. I will say, though, before I go on I hope I underline that of the thousands of people who work on these projects, almost all of them are serving their own communities, really, and most of them are community health workers, accompagnators, and most of them have never had a job before. And that's one reason I'm always anxious about keeping this ship afloat. My version of sustainability is, for us to sustain our commitment, and because these people need those jobs, and they do them well, but they also need them. Back to 5th grade, in my experience in Haiti, less so in Africa, but in Haiti, the aspiration for people who drop out in 5th grade is to go back to school, even when they're 20. And I personally feel very uncomfortable saying, you're too old, go be a community health worker. So there's these many years of struggle, the teenage years, where we're really fighting to make sure that they can go to school. And that's one of the reasons Partners in Health is so obsessed with the right to education. It's because we want to not have to be the ones who build the schools and staff them poorly. It's not really our area of expertise, but that's what we're doing now for about 10,000 students. But yes, the answer is all these people are trained by Partners in Health and end up serving their own communities. And we do talk about service, notions of service. And so there's building human infrastructure for public health in addition to building the bricks and mortar stuff that I talked about. That's why I showed the costing slide, because we think it's so important to build this human infrastructure. Sounds like a weird metaphor.
We have a question in the back of the room.
Hey, Paul. How are you?
How are you?
Thanks for coming.
My pleasure.
I want to ask you about your throwaway comment at the beginning of the talk, where you suggested that you probably wouldn't want your surgeon or a lab scientist to take a social perspective on medicine. And I wonder,
During surgery.
during surgery, what in some sense might be the way in which we should rethink healthcare in general, the delivery of clinical services, that also might be embodying a sort of social perspective, and particularly think about medical education, so that we're actually producing doctors, as, for example, they often do in Cuba, who expect to have a social orientation towards the work they do, sort of built into the fundamental health clinical practices themselves.
Yeah, I didn't mean to give a throwaway comment, and it really was. Of course, if we have every branch of medicine and nursing, and ought to take this perspective, I think, right? Social medicine. How would that play itself out in surgery? Well, I was just joking that you wouldn't want it to do it as they're making the incision. You can just say, so how about Weber? Not so good. But I'm sorry, it was a social theory comment. That said, I go to these conferences on surgical disparities, and there's starting to be more of them, I'm happy to say. Actually, there's one here last year. And we need to link worlds together. For example, the average American will have 12 surgical procedures in his or her lifetime. The average rural Haitian have 0. So it's not a bad thing to move some of those surgical procedures down to Haiti where they're needed. When I was working on a project to increase access to modern obstetrics in Haiti, at the same time that another colleague of mine was working in Mexico to decrease rates of cesarean section. I said, gee, our activism is canceling itself out. So that's how sick the disparities are. In some places you're fighting to reduce, that's terrible. You're fighting, and it's not like there's really 3 worlds, first, second, and third. And rates of cesarean section, I don't know why I'm perseverating about this. Well, I do know why. Among the upper middle class in Haiti is the same as it is in Berkeley, probably higher in Haiti. And so it's really all about, it's about disparities between rich and poor, not between nation state and nation state. So back to training doctors. If you're going to have a conference on surgical disparities, you want everybody in there to understand that the disparities are not just local, they're translocal. And that takes some doing, and it's been a big struggle in medical education. I didn't confess to the public health students who were, I have to tell you, Jim, that they were asking, could we make some of this work more mandatory? And I didn't confess that I teach a required course at Harvard Medical School, and I'd love to not have it be required. Because social medicine it's called, and about a third of the students love it, and a third don't care, and a third really are irritated they have to take the class. So I, wanting to win a popularity contest, would like to not have a required course. Fortunately, I have more principled colleagues who insist. But you have to work that into the curricula of schools of medicine and nursing. And we wouldn't be starting again from scratch. There's lots of historical work. There's other countries that are doing a better job. And then there's also the fits and starts that we've had in this country already. And I'm sure Berkeley doesn't have med school, but I'm sure this part of the country is no exception. I just would say we got to forward that social medicine approach.
Hi. Thanks a lot for speaking, actually. It's really an honor to see you. Thank you. I'm not in public health. I'm actually a sustainable MBA student, and we talk a lot about
Does that mean you're in school for many, many decades? You have
Hopefully
a
not.
sustainable MBA?
Hopefully not. We talk a lot about the human aspect of sustainability, and I know that you're already tackling a huge amount of things, but one of the things I really admire about your work is that it's a multi-pronged approach. And I just wonder if you're partnering with any organizations or anything to sort of address the disproportionate, because the, people in developing countries are going to be disproportionately affected by climate change. Yeah. So is there anything that you're doing around that or sustainability?
Yeah, well, the answer is yes. I mean, we're working in order to promote food security, for example, in Haiti or other food insecure places, it's really an ecological problem already. I mean, all the trees are gone. That's why hurricanes wipe out Haiti so badly Hurricane Ike, which just trashed Haiti, some of you would have been there, hit Cuba even harder. And you had 800 people die in Haiti and 3 in Cuba. And they didn't die from the hurricane, they died because in evacuation accidents like with Rita, et cetera, here. So, yes, especially around the ecological disasters. Are we doing it enough? No, we have to keep on going. We've been working with, unfortunately, with some of these groups, there's so many NGOs that are not coordinating. That's, again, this 1,000 points of light thing. So we're working with one NGO on transforming agricultural waste into, fuel for families so they don't have to cut down trees. And, there are lots of small efforts like that. But what we really need, as I was arguing to these people in San Francisco earlier, is to bring the social justice movement together with the environmental movement. And we need, as Paul Hawkins said in his book, we actually need the environmental movement to get on board the social justice bus, not the other way around. So it's the same for business, sustainable MBAs. It's really the social justice bus that we need to get on. And the one thing I would say that I would encourage you as a student in a program with that title to do is to have a critical sociology of the word sustainability. What's that mean? Where's it come from? How's it applied differentially? And that's a very important exercise around these terms that I've been critiquing here, cost effectiveness, sustainability. It's not to be a troublemaker. It's to get a good handle on what it is we do and why we're doing it and how it works in the world. So I'm all for it. Thank you. Yes. Well, I shouldn't. I'm not driving. You drive. But if it's too far away, just yell and I'll repeat.
Hi, thanks for coming. I wanted to ask you a question about your suggestion that NGOs get involved in public sector approaches, and I understand where you're coming from in the sense that public sector's resources reach a huge number of people and they confer rights. Everyone has the right to use them. But how does that work out in a developing country that has low infrastructure and suddenly usually foreign NGO with a lot of foreign money sweeps in, builds up an infrastructure, and suddenly sort of owns part of the country? I was working in Cambodia. I saw that happen where basically the country was being run by foreign aid.
Yeah.
And so how do you balance working in the public sector with basically not taking over the government and country?
Yeah.
Thanks.
Well, that's a great question. I'm glad you mentioned Cambodia, because when I talked earlier about desocialization, of course, there's a reason that Cambodia is Cambodia. I mean, if you carpet bomb a place, it doesn't look good afterwards. There's a reason that Haiti has a weak public sector infrastructure. If you keep funneling money to people who are going to overthrow the governments when they're elected, then that's what it's going to look like. The United States, by the way, since 1915 in Haiti, happily, we invaded Haiti in 1915. A fact I didn't learn growing up in Florida, just a couple hundred miles away. And the Marines the U.S. military ran Haiti for 20 years. FDR withdrew the troops in 1934, and I think words like good neighbor policy were used then. So that's the backdrop, and we kept on funneling, as a government, our government, money into, a friend of mine from Guatemala is nodding, same story there. We kept on funneling money into the Haitian public sector until, guess when? Until they actually elected their own government. And then we stopped. Then we cut off the aid to the public sector. Now imagine that. Now, I'm going to something with a couple friends of mine are here right now. We're going to an event about this, I think, tonight. At least I'd like to make it about this. So, and I have every intention of doing so. So that's the backdrop, and that's the tough thing is these NGOs because they come from rich countries, Europe and North America. Those are not countries, Sarah Palin. That's soon going to be. They're going to say, who's that? That the Sarah Palin humor is out. Anyway. So the problem is the political economy of the world means that some places that are wealthy have the ability to go in and have these big NGOs that can build infrastructure and then not own it. All the time that happens in Haiti. So what are we saying? We're being very pragmatic. We're not saying, we're saying understand your history, whether it be carpet bombing or overthrowing governments, not to be a seminar room warrior, but because you're going to re-socialize for our understanding of foreign aid in Haiti. And then you can make some sometimes very modest steps to improve. Like, for example, our improvement is only in the public sector facilities for those two reasons, scale and rights, but also because we recognize that we have not done well by the Haitian people over the last couple hundred years. Now, I was on the phone last night in San Francisco already arguing with colleagues of mine, we were arguing, how are we going to get this other large NGO hospital to play nice in the sandbox? And it's not easy. It's not easy in Haiti. It's easier in Rwanda because the Rwandans say, you know what, you have to work together. Here's our district plan. If you don't like it, there's the airport. But most countries, including Cambodia or El Salvador, or maybe El Salvador in the future, they don't do that. They just roll over because of the colossus. And sometimes it's even Canada, but it's usually the United States in this part of the world. What used to be France and that part of Africa, because that's what they say to do. But we have to be on the side of those who say that is not the right way to do foreign aid. We rebuild public infrastructure so that people can have the right to health care, and we also rebuild other stuff that we wrecked or that our allies in those countries wrecked. I think that's a perfectly good thing to do. Reparations. I don't care what you call it, but it's reparative in the redemptive Catholic sense too, if you'll forgive me. Yes. You have 2 microphones.
I'm just curious, with community health workers in the United States, if you've encountered resistance from groups who see that as their domain, like nurses, for example?
Yeah.
And what success you've had with getting buy-in from that group?
Yeah. Well, it hasn't, I'm glad to tell you, on this small scale, not a lot. Visiting nurses, been supportive. I mean, I don't want to, like I said, I have a witness here, so I don't want to overstep. Visiting nurses. There aren't a lot of, first of all, as Jim Kim often says, there's not a long line of people waiting to serve the poor. So I've already told you these are underserved people. There is some resistance, but it tends to be turf-oriented, like, oh, that person belongs in my catchment area or my clinic. They're not really arguing about community health workers, which is good. So the resistance is very turf-oriented or around reimbursement and insurance. Now, believe it or not, I was delighted and a little bit surprised when we got some of the insurers to start considering, whether or not this was a good investment for them. And even some of our funding came from Blue Cross Blue Shield Foundation. Now, that's not the same as Blue Cross Blue Shield, the insurer, right? But at least they're paying attention that when we say this gives better outcomes at a lower cost. And I think that's going to be true anywhere in the nation. And if we could move this forward without generating a lot of heat from providers, because really visiting nurses still they're not community health workers. They're highly trained professionals, have gone to school for years. Some of them are nurse practitioners too. And we're talking about lay people who we can train very quickly to help extend the effectiveness of any provider, social worker, nurse, or doctor. So I think I've been happy to see not a lot of people saying, you're cutting into my turf. So, thanks. It's a good question. I'm going to stop pointing at people.
Okay, I have more of a personal question.
I'm a Scorpio. Next.
Yay! I'm a Leo. At what age did you discover your love for the work you do, and is there like a particular experience that led you to know this is what you want to do in your life?
Yeah, thank you.
And then also, what method would you suggest for expanding the percentage of service versus research and training in universities? 2
good questions. Well, I'm glad to be able, how many of you are undergraduates, by the way? I'm glad to be able to answer that. And again, I have another witness who I met when I was an undergraduate, as a professor here. I started on this this track that I'm still on now when I was in college. I took a class. So when I talk to universities or colleges and say, study hard, you may find something you really like. It was a course called medical anthropology. And I remember the place and the professors and the year, everything. And then I got interested. I was a biochemistry major. And I stayed with medical anthropology for lots of reasons. And sometimes I would say, well, it's not that you get this secret cultural knowledge of a place. It's that you understand social process and social theory and also what you don't know. It's been very helpful to me. So the answer is when I was an undergraduate. Now that led me to Haiti, and Haiti is where the epiphanies really happened to me more than anyone else. And some of you have been to Haiti and know what I mean. But I still regard Haiti as the best teacher I had. But it was really being in a class and studying with medical anthropologists really and others that led me to Haiti. And to the second question, what formula or methodologies, what you said, I don't know. I mean, reading this article this morning about public universities and the challenges they face, I'm sure that it's going to be different from place to place. But if you have, there are various, the dean from the School of Public Health is at a meeting of deans, right? Not UC deans, but I think School of Public Health deans. There are all kinds of professional associations that link universities, including the administration. So I think it would be really good to have universities fiddle with that question. What are the methodologies we might use to get an answer? But I'm just saying it can't be 1 or 2%, and it can't be as if it's a hobby for the students. It has to be a serious question. So you get the college president. My close friend, coworker Jim Kim, as some of you know, is going to be the next president of Dartmouth University. And he'll certainly be asking questions like this. And I think the administration of certainly of schools of public health and medicine ought to, and nursing when they're around, but also just the university writ large. So I don't know the answer, but it ain't 2%. It should be a substantial part of what we do. In part because that's what the trainees want too. The students and the trainees, they want to be involved in service. So why deny that? Why say that's not our brief, that we don't do that? It's not a smart thing for universities to say. They should say, yes, we will embrace that role and do a better job of it. Have it be properly mentored, have critical discussions, make it sort of. You can't require service that backfires, like military service, but it should be encouraged and regarded as something other than a hobby or a pastime. Thank you. I know that we've been ignoring this other room. Sorry.
Hi. Do you know if your perspective on public health, if that's being considered and talked about in the meetings the Obama administration is, when they're talking about universal health for the United States?
Yeah, I have the White House bugged. I have listening devices. I don't know. I mean, actually, I was asked that this morning on this public radio show. Your Bay Area's beloved Michael Krasny, he asked the same thing. I have had the good fortune to talk to the nascent administration about these issues, and I think there are lots of people who could do just as good a job as I might, who are being listened to. I would, of course, I want to be part of these exciting conversations about how to rethink medicine and public health here and elsewhere, and also foreign aid. So I think it's early in the game for me to say, no, not really. And I'm sort of saying more, I hope so. And it doesn't have to be me, but people who might represent these views regarding the need for fundamental change in foreign aid and medicine and public health. I think they're open and willing to listen. They're a little distracted. Yeah, I'm sorry. I'm going to switch over this side. Oh, yes.
Thank you again for coming.
And then
my question is a little bit similar to some of the ones they asked here, and I'm not public health, I'm a nurse. And so this community health worker model is such a great model, and it's been working clearly in the countries that you talked about. Is there the possibility that we might be able to see this model more in the United States, but more working, for example, with the universities, where the students, because there's this whole wave of activism, maybe the students could start doing this and maybe make it, I don't know if it would be working with the university, getting set up, but the student actually maybe gets credit for it, gets some sort of reimbursement on their tuition. And because the economy is so bad right now, and a lot of people are going back to school because a lot of nurses can't get jobs, and there is this need to go work in the community. Is there a way that we might be able to see this happening? And is there a way that Partners in Health can somehow spearhead this movement all across
the land?
And how do we get you to work with Obama?
From sea to shining sea. I went to this beautiful apartment in San Francisco last night, and I looked over, and there's this gorgeous red bridge, and I said, "Oh, the Bay Bridge." And everybody went, "That's the sea to shining sea." I have to work on the sea to shining sea part. I think that it's a great idea. We're doing it now. There are things that are apparent to you that won't be apparent to everyone here. So-called HIPAA issues, patient privacy, whatever. Those I think can be worked out. I think that we should. Now, if it's a nurse who goes back to school, that's a very different thing because that's a licensed healthcare professional. So we can always incorporate clinicians of that high level into community-based work. I think at the same time we should also develop a professional cadre of, I love saying that word, it sounds so che. I'm trying to make a friend of mine laugh. I think I succeeded. Where was I? Sorry. I think we need to develop a professional cadre of community health workers who are formerly lay people or trained, and then find some licensing for them. There is a National Association of Community Health Workers. We are Partners in Health is a small player, as you might imagine, But we're trying to be part of that coalition, and we'd like to see it spread in the way that you have. And universities have a big role to play there, too. You know, I work for a small community-based college in Cambridge, Massachusetts, and it's been our springboard. It's been our springboard for a lot of this work. I know that I had said I would. There you are. You even got a mic.
I got a mic. Is this? Yeah. So I was intrigued by what you described as population-based rights.
Yeah.
And I was wondering if you could
I just made that up today.
That's too bad, because I was hoping you were going to inform
I have
me
written about it. I'm
something
kidding.
important. Well, I'm curious about the difference between the right to health as it's often conceived of in this country, which is the right to whatever surgical operation you might choose or something like that, as opposed to a population-based right to health, which is more about primary health care. And I'm wondering if you could talk
or
about
surgical care, too.
Okay.
Just not,
Yeah.
you know.
But I wonder if you could talk about sort of a global perspective and also from the legal perspective, what kinds of rights are actually codified?
Well, you know, I'll just say, I'll be brief on this. I should be done in half an hour answering that question. Those are really important questions. And I would say, legally, there are already conventions, you know, for social and economic rights. As many of you know, our country is not signatory to the Convention on International Cultural and Social and Economic Rights, but most countries are. Now, so the framework is out there. It's a good, perfectly fine framework. And if you're interested, there's a journal which I happen to edit called Health and Human Rights, which is online, in which, you know, we try to take this on with every issue. We've just done our second issue, you know, since I've been editor. It's all about this topic. But now let me go back to the difficulties of implementing, of having legislation have teeth. You have to have compliance, that's the easy part. But you also have to have the tools that you need to do that and resources. So I was speaking to a head of state. Now, how many heads of state do I know? Not many. But this one, I won't mention who, but it was the democratically elected head of state of a small country in the Caribbean where I've done some work over the years. And I said to him, given your commitment to social and economic rights, which is all true, you really ought to sign the International Convention, the International Covenant, rather, on social and economic rights. And he taught me something right then and there, as he has before through his writings and comments. He said, you see, this is possibly going to be another trap by the rich countries to have poor countries be punished for being unable to enforce their own treaties. And I said, what? What are you talking about? I said, well, I mean, we signed onto a treaty. How can we provide the right to health care when our budget for the whole country of 9 million people is less than the budget, he didn't say this, but I'll give you a number, is less than the budget of the city of Cambridge, Massachusetts, with 100,000 people. So the shortfall for this university is larger. Well, that makes it sound bad for Berkeley. Strike that for the... I was going to say the shortfall of this university is larger than the whole national budget of Haiti. So I get that. You know, once I thought about it, I understand why it's easy to have exhortations, but you really still need a social justice movement around things like debt relief, fair trade, not using foreign aid as a political tool. And that's really first world activism work, if you ask me. And I think that's something, you know, again, universities and student movements can get involved in. You know, there are people in this room who have been involved from California on some of these issues around Haiti. And it's been very, very, at least helpful to know there are people out there listening and yelling about some of these really unfair, the unfairnesses that basically make a lot of poor countries unable. There are also those who are unwilling, but unable to really execute in this, you know, a social and economic rights strategy. One last thing I would say that's very troubling, but I'm just going to bring it up. I read Mahmoud Mamdani's piece in The Nation about the ICC. Did anybody else read that? It's scared me. It's about Sudan, Darfur, and the International Criminal Court. Look it up. Read it. It's about sovereignty. It's by an anthropologist named Mahmoud Mamdani. It's about sovereignty, and sovereignty is a good thing, I think. You know, and it really talks about the new human rights regime and how it fits with basic neoliberal policies that have been promoted by some countries and objected to by others for a long time. Very chilling. I did my first blog about it, my first ever blog. You know, and it was for a pretty well-known edited blog in New York City. And people said, oh, you're really going to love this new I didn't know what a blog was. I didn't. And they said, you're going to love blogging because people get to respond to you immediately. it was annoying as hell. It's like people had it's like anybody can respond, and completely unedited, uncensored response. So I didn't do any more blogs after that. But I blogged about that article because it was so worrisome to me, as someone who obviously is very alarmed by what's happening in the Sudan, but also alarmed by some of the responses to that violence. Yes, Jim. Oh, this is the hook.
No, this session is being sponsored by our new Center for Health Leadership here at the School of Public Health. And I wondered if you could share some of your major lessons about being a leader and making the kind of change that you've been able to make, and the kind of advice you have for students who are aspiring to be leaders.
Well, thank you. But actually, I'm not so much a leader as a hero, according to Berkeley. I want to thank Berkeley, by the way, for the honor tomorrow. Don't think if I start taking myself seriously, game over. We talked a lot about, and some of the key lessons. My lessons were that we discussed were driven by their questions, but I think some of the things that I've learned now, looking back, I shared the things that I shared today about the public sector for scale rights and rebuilding, go back to some of the questions that are raised. I wish that had been obvious to me. That's a key lesson. Most public health people know this already. I shared the lesson that here's another one that I didn't put in these words, but I will try this formulation. When we set policy in public health, enshrining low standards of care as policy is not wise. For example, if we say, what is the highest standard of care, and then focus on getting there. And I said this just for the first time a couple days ago to some students, the American Medical Student Association, and they said, but you like the Millennium Development Goals? And I said, yeah, but I'm not sure we should call them the Millennium Development Goals. We should call them Millennium Development Path. Because the path needs to be equity. The goal needs to be equity. And the path is the strategies that we lay out, the work plans, really, of how we might get there. That's a second lesson, is don't say, well, you're living in Ouagadougou. All right, let's go for it. You're living in Burkina Faso. Therefore, your amount of money available is X, and here are the interventions that you should prioritize. That's the way a lot of global health is being done. Well, is that really the best way to... You can't do anything with that kind of money. You can't even have a basic vaccination program. So I think the social justice component of thinking about distribution of the world's wealth is a perfectly fine one for public health, as it was in the 19th century. So that's another thing. We need to revive that way of saying that. We don't want to make people uncomfortable. We're not going to hoot and cheer and throw fake blood on people. But we really need to revive this social justice perspective and have it inform our public health work. That's another lesson. I kind of could say I went in with that, but it's not really true. It's something you learn in the field. How do you do it? How do you go? Now, a fourth thing that I didn't say, but I'll say right here, is learn complementary paradigms for action. That sounds, again, very nerdy. Learn complementary paradigms. For example, if I'm going to go to meet with my patients and ask them for something, because we do ask for things from patients. We not just fly to Boston and give a talk, but help us organize and improve services, or you should join us now that you're better. I'm just thinking of AIDS patients for some reason because I talked about them as an example. I'm going to have one way of talking to them as a doctor might, and it's perfectly fine to use rights-based paradigms. I use them all the time. I talk to students about rights paradigms. I write about them. I get University of California or Berkeley to publish my stuff about them. But if I go to speak to an official in the Ministry of Health, or maybe a president or head of state or parliament, I might instead focus on the paradigm of economic development, because I know that's what they want to hear. And it's economic development, good. Poverty and disease, bad. So how can we break that cycle of poverty and disease and contribute to economic development? I'm perfectly happy to stoop to that level, happily. And then third, another complementary paradigm that I can use with surgeons, say, or doctors, is what about public health? What's the paradigm for public health? And we have one, public goods for public health. So tuberculosis diagnosis and care is as free in California as it is in Haiti, because it's an airborne disease, and people have decided, this is an important public health priority. Let's learn how to talk public health. So those are three complementary paradigms: human rights, economic development, public goods for public health. And I guess what I'm saying to the students is be quicker than I was to learn how to master these paradigms, because they'll be very helpful as you try to push forward public health goals, which should be set high. Love, Paul. How'd I do? Lessons.
So I don't know if I want to end on this question, but I just have to say I'm a huge fan of your work, and I think everybody here is very, very inspired.
Is that going to preface a mean question?
Well,
I just want to say I'm a
perhaps
fan of your
a
work.
devil's advocate question.
How did I guess?
But I'd love to hear you address this. What would you say to those who argue that drug prices should stay high in certain parts of the world, at least, so that drug companies are incentivized to continue research and innovation?
Well, I mean, I'm not against that argument at all. All right, I think that some places in the world, particularly the United States, are carrying the lion's share of the research compared to other rich countries. Now, that said, you know, how much? How much of the money goes into research and development? How much goes into advertising? Let's get some smart, scholarly people to break it on down, as they used to say in the 70s when I was 12. I'm gonna indulge in one. I think it's being taped. I have to be careful. But since Michael Krasny this morning in front of whatever listening audience he might have, people called from Columbus, Ohio, I noticed. He said, "So I hear you were with Clinton on a 48-hour trip to Haiti this week." I was like, "How did you know that?" It was in the papers. I didn't ask him, "How did you know that?" I said, "Yes, that's right." And I was. The story is that, you know, everybody, you guys know he has a reputation of just being the Energizer Bunny. Like he can stay up and talk and talk. And we were in Haiti, and it was outside, and we were talking. He was talking about everything from gun control to foreign policy. It was really great. And I was with a Haitian friend of mine. She said, "It's 1 o'clock in the morning. Do you think I can go?" And I said to her in Haitian Creole, "No, you can't. You're the only Haitian here. There's a small group, and it would be bad." It's loon. And at 2 o'clock, she said, "Can I go to the bathroom?" I said, "Yeah." But at the end of this, I have to tell you, I was thinking, wow, you know, he can talk about anything. How come I can't talk about anything? And I went to bed thinking, I got to do better and read more, or know about the Middle East. I don't know. And so the next morning, I woke up and said to myself, "Self, if we were talking about management of infectious diseases, I'd also sound like a genius." So then we fly back to Washington. That night, he's on Larry King Live talking about healthcare. And he still sounded smarter than I did. So that was annoying. But what he said on that show, which I'm sure is something you could, webcast, whatever, pull off the great internet in the sky, is that even with recovery, even accounting for the fact that the United States is paying the lion's share of the research investments, we're still paying way too much for the drugs. And he just started doing cost comparisons with other rich countries. And I knew it was big between Canada or European countries, France. I didn't know it was that big. And so I think doing what he was doing that night, and there's probably some people in this room who know a lot more, we just need the numbers, the real numbers. And I think we should work with the pharmaceutical industry to ask, come on, out with it. Let us see what the numbers are. And can we have some cost sharing with other affluent countries? Because if that's the problem, get the French to cut down on their wine intake and start investing in basic science, whatever. Because the argument that President Clinton was making on Larry King Live was that these are of universal benefit in rich countries, but the U.S., both research-based pharmaceutical and the universities are doing more than their share. Now, I mentioned already Universities Allied for Essential Medicines. I think that group, and there's a nice robust chapter here. Anybody want to raise their hand from UAEM here, the student group? All right, some people over there. Connie. They're working on getting some of the numbers and looking at how universities, including public universities, relate to the pharmaceutical industry and the patenting process. And I think that's all to the better for all of us to understand how that works. And that we need basic literacy on this. And we don't have it. We don't have it in medicine or nursing or just as citizens of this country. And I think it's a good thing to develop. I'm trying to develop my own, so at least sound as good as President Clinton does. That's the hook. Do I leave now?
Hello, my name is Naya Vamurkam. I'm a member of the Center for Health Leadership Board. I just want to thank you one more time and give you another round of applause for
Thank you
the work.